Hi, everyone. Welcome to GUTS in the virtual community. This is our second event of the year, and we're going to the slides right now. So GUTS in the virtual community will occur every fourth Tuesday and is essentially an event to provide clinical research awareness where we invite speakers to come and talk about their various expertise. You may follow us on Facebook, GUTS Community, as well as visit our webpage, and the link will be shared in the chat. GUTS in the virtual community was put together by a core team of members from Howard University, Georgetown University, MedStar Health Research Institute, the DCVA, as well as collaborators from our Participant Advisory Board, the Community Advisory Board, our Community Engagement Team, and the MedStar Center for Health Equity Research. At this time, I'm going to introduce our moderator for tonight, Dr. Fanny Richardson. Dr. Fanny Richardson is an instructor and grant program manager at Howard University College of Medicine and Department of Community and Family Medicine. She obtained her doctorate of philosophy, master of public health, and bachelor of science degrees, all at Howard University. She conducted biomedical research, and in her current role, she's currently implementing clinical community engaged quality improvement studies to address cancer disparities, opioid use disorders, health literacy, and communications. Dr. Richardson, I'll go ahead and hand it over to you.
Thank you, Emily. I'd just like to welcome everyone this evening. We're going to have a great discussion and we're going to talk about it. Let's talk about it. I'd like to introduce to the community the GUTS and actually what GUTS is all about. So what is GUTS? Why do we need diverse groups in research volunteers? And tonight we're going to discuss changing the narrative, which saves lives, clinical trial participation, and all of your vaccine concerns. Please leave any questions that you may have in the chat box, and you will have the opportunity to ask any questions that you may have at the end of the presentation. So introducing GUTS. GUTS is actually the Georgetown Howard University Center for Clinical and Translational Science. And our motto is, it takes guts to make a change. This is a partnership between medical institutions that are created to transform clinical research. And by doing research, we're able to identify new treatments and cures for diseases that can be delivered to patients faster. And it is our goal to increase health research awareness to the community. And that's exactly what we're doing this evening. We support researchers who design and implement research that will have a high impact on all communities. So we want all communities to have access to research. We want it to be equitable, and we want to aim and strive for equality in our research scope. So some of the resources that are available through GUTS, we have Research Match. And Research Match brings together people who are trying to find research studies and clinical trials that they may be interested in. And so through Research Match, it makes it easier for you to find the right match for you as well as your family members. We also have at GUTS what is called We Partner for Research. And at this website, there are many resources that are available, including information about clinical trials that we're going to discuss this evening. And so these resources were created to provide information about misinformation that can often be found about clinical trials. So GUTS is here to make sure that you have access to credible and trustworthy information as you consider your research options. So as I mentioned, let's talk about clinical research. Again, we here at GUTS, we try to encourage participation in research for all communities, those that are underserved, those that may not have access or even have awareness of clinical trials. And so we thought that it was important to put this website together so that the community could understand research terms that you may be hearing and that are reported in the news. And it's important to have research information available so that you can make informed decisions about your health, about your participation in research, because you do have a choice. Participation in research is voluntary and it is a choice. We also wanted you to be informed about how people should take part in research and how they are protected. We'll talk about it a little later, but we're no longer operating within the times of Tuskegee, in which individuals did not have that option. They didn't make an informed decision. And so there are many protections in place. And most importantly, we want you to know that if you are interested in research, how can you find about research and studies that relate to you and are similar to your health and can address your health conditions? So what is research? You know, it's a buzzword. We hear it all the time. Many people may associate it with, I don't want to be a guinea pig. That's not what research is. Research, and specifically health research, it is the process of testing new ideas and treatments, and it helps individuals learn and find out how to prevent, how to diagnose, how to cure, and even treat illnesses. So for individuals that have maybe tried all the available treatment options, research is there and available as an additional alternative option to all of the other treatment therapies that may have already been available that you may have already tried. And so research is available and many people participate for many, many different reasons. So what are the benefits of research? Researchers have been able to make such advances in health by finding about, and researching different types of treatment. As you know, you can see within the pandemic, we have the COVID-19 vaccine that has been created, as we know, in warp speed. This is a primary example of exactly how research can operate, not just in the lab, but it can be translated to the community, where on a mass scale, the community is participating and getting the vaccine, the COVID-19 vaccine. This helps us find better treatment, not only for COVID-19, but also for cancer and diabetes and many other health conditions. Research provides access to new treatments. And many people decide to participate, as I said, for different reasons. Some individuals want to participate because they know it is their civic duty and they're able to help others. They can somehow help their loved ones or other family members avoid some of the situations that they've been in, maybe avoid some of the symptoms or just consequences of their condition. And so research is available to provide better options and better treatments. So many people take a part in research to help discover ways to improve the health for future generations to come. This picture that you all are seeing is very near and dear to me. These are members of the Participant Advisory Board, in which I work closely with. But I wanted to highlight here this quote, that there's a growing recognition within the Black community that its members can't be absent from clinical trials and expect medicine to work as well for them as it does for other populations. We have to be included. And so this speaks very near and dear to the importance of having representation of many communities in research. The African American or the Black community is not the same in Washington State as it is in Washington, D.C., or even our neighboring communities such as Maryland and Virginia. And so our genetics, our environment, it is all representative of where we live, where we work, where we play, where we, worship, where we gather in the community. And so as a result, we have to have representation from multiple communities in multiple places. And we also want to make sure that we're not only representative, but that there is a level of diversity so that we are truly represented, whether it is by age, whether it's gender, whether it is, economic status. All of these things matter. And so at this time, without further ado, I'd like to introduce our first guest speaker, Dr. Dahlia Wesley. She is a scientific director of the MedStar Center Health Equity Research. She is also an assistant professor at Georgetown University School of Medicine. Her research focuses on the unique factors impacting how racial and ethnic minorities access and utilize health services. She has expertise in health disparities and patient-level factors that impact communication and influence health decision-making. At this time, I'd like to turn it over to Dr. Wesley. Welcome.
Thank you, Dr. Richardson, and thank you for the invitation. Really appreciate being a part of this really important discussion. And I want to spend just a really brief amount of time touching on some of the key issues with clinical trial enrollment across the nation and the need for diversity among research participants, and then really briefly touch on some of the early work that we did at MedStar Washington Hospital Center at the Cancer Institute there to try to address the low recruitment rates, particularly for Black patients in oncology trials. But what I really want to do is yield as much of this time as possible to our next speaker, who I'm really thrilled and excited to work with and have been working with for the last 2 years, and give you a bit more of an introduction to her. I've had the pleasure of working with her on generally focusing on communication campaigns, addressing specifically racial ethnic minorities. And the work that she's doing right now, I'm just so impressed by, and I think you will be impressed by, and is relevant to the conversation that we're having right now around communicating around COVID-19 and the vaccine. So I will be brief. Without much further ado, so let's talk about clinical research and why we need diversity among research volunteers. We first have to look at the definition of health equity, and here is an abbreviated version stating health equity means that everyone has a fair and just chance to be as healthy as possible. And I would actually push on that and say that everyone has a fair and just opportunity to be as healthy as possible and to maintain that health. And so when you think about clinical trials and the potential benefits of clinical trials, ensuring diversity in research is one of the key ways that we can also help to strive towards achieving health equity. And so having diverse groups provides us confidence that any results that we're learning from clinical trials, any findings, they actually apply to a wide range of people and not just those who not all of the people who are actually represented on the trial. And then it helps ensure that everyone can get the treatment that is best for them. And of course, without being on the trials, we don't know if it is best for all of the groups that are not represented. And so in looking at who is actually on the clinical trials, and this is across the nation again, you see these patterns or these numbers, these proportions, across different clinical conditions for different drug trials, treatment trials, et cetera. And if you look at the chart on the right, you'll notice that this shows us who by race ethnicity is represented on the average on clinical trials. And you'll see an overwhelming, in fact, the majority of participants are Caucasian or white participants or other. And so that's 94% compared to 5%, which is a lot smaller, of Black or African American patients, and then a mere 1% of Hispanic Latino populations. And then on the left, just to make a comparison, that's the demographic makeup of the same groups within the United States. So you'll see about 72% of the United States population are Caucasian, and then 12% are African American, and then 16% of those participants, or the population, are Hispanic or Latino. So again, looking at the two side by side, you see that there's a really gross underrepresentation of these racial ethnic minority groups on clinical trials, and that should be really, really concerning to all of us, especially those from these groups, considering the fact that if our trial makeup doesn't reflect what our actually countries make up, that's a real concern for the populations who aren't represented on trials, especially when we think about the opportunity to benefit from what we learn from science, what we learn from the research, and most important, the treatments that we're developing from these studies. And so in addition to making sure that the treatments work just as well for everyone by having representation on the trials, there are a lot of different factors that we have the opportunity to learn when we do have diverse research volunteers and participants. So there's factors such as a person's age. We need to understand what range of side effects come with what range of ages. So we have to have representation from all age groups on those trials. New drugs may very well interact with any number of medications or medicines that a person's taking. However, if we don't have those people on the trials, we don't have the opportunity to learn what interactions, what safety issues there might be. In addition to that, we know that there is genetic variation among all populations and among diverse participants. And so without that diversity in research volunteers, we don't have the opportunity to understand how genetic interactions or how people's medicine or how their genes respond to a certain medicine. And ultimately, you know, and the piece that I always like to highlight is given clinical trials are really the key to giving people access to the newest medical treatments. And in, you know, the field that I started this work in oncology, we really saw major advances and improved outcomes for participants based on their willingness to participate in clinical trials and try new therapies. And so there are plenty of documented reasons. For years now, this work has been done in terms of why people are not included in research that are diverse and representative of the population. There are plenty of documented reasons both on the patient side and on the provider side. And there are also a lot of documented reasons on the institution side. And we sort of know what these are. And I'll touch on a quick few on the patient side in terms of the study I'll present. And then there are a lot of known provider barriers that are talked about. So for instance, the lack of diversity in research can also actually be because of the researchers' own biases, whether it's how the trials are designed, things like inclusion and exclusion criteria, and then also just personal biases in terms of who is even offered a clinical trial sometimes by a provider. And those are things that I think are not talked about as much. So for example, and we have here, a researcher may think based on their own biases that a person with a disability or a person who's differently abled cannot take part in a research study. And the fact of the matter is that it's actually the complete opposite, in that we have to make steps to make sure that people with disabilities can access research in the same way as others. And then this idea that researchers have to also recognize, and again, along the lines of these biases, that people express their gender in different ways. And so understanding what that means in terms of their eligibility for a trial and what may be right for them. And so in thinking about clinical trials and representation, on the next slide, please, you know, the question is, all that said, is it important to include diverse groups in COVID-19 studies? So the very right now issue of the hour, and the answer is yes, absolutely, of course it is. You know, the COVID-19 virus clearly does not discriminate in terms of who it infects if there is an exposure. It's true that there are structural and other factors that make some groups clearly more susceptible and disproportionately so, we know, racial and ethnic minorities and other minoritized groups. However, having that diverse group of research volunteers, especially for something that is so salient and that is, you know, at the core of our existence right now, really can help make sure that those very same groups that are overwhelmingly impacted also stand to benefit by being part of these trials. And so ensuring that the results from any current COVID-19 studies, vaccine studies, apply to as many people as possible. And so on the next slide, I want to really briefly touch on some of the patient level factors. And one of the interventions that we had a great success with a few years ago at Hospital Center at the Cancer Institute, focusing mainly on the patient level barriers and touching on things that are very real and justifiable reasons for the resistance and hesitancy to participate in clinical trials, especially therapeutic or treatment clinical trials. And so we focused on a method of communication that was based on narrative communication and storytelling in this clinical trial specifically for Black patients and specifically for patients who had an active cancer diagnosis. And what we aimed to do was to first develop a patient education video as a means of intervention, touching on the very specific attitudes that we know are salient within this patient population within this community, and then actually doing a brief intervention trial to ensure, to test, to see if this intervention would work. And for this, the communication methods that we use, we knew from different studies that have been done that this communication method works very well to reach the population of interest. And so again, the focus on the initial trial was looking at the race-based disparities that we see in breast cancer. Absolutely true and very glaring in Washington, D.C., but similar across the nation. And so looking at, so on the chart on the right, the pink line you will see is white patients, and on the black line is Black patients. And so you'll see in terms of incidence, in terms of who's getting cancer at higher rates, you'll see the pink line is above the black line, meaning there's a higher incidence among whites, a lower incidence among Blacks. However, the mortality is a flipped pattern and very concerning though. So even though Black women tend to get breast cancer at a lower rate than their white counterparts, they are much more likely to die from it and to get more severe disease. And so the consequences, there's a major gap leading to a lack of clinical trial findings. And when you recognize that Black women are also not as likely to be on the clinical trials, and you see these mortality patterns, it's a really, really concerning outcome. And so important in breast cancer care where these racial and ethnic disparities exist, but then we also expanded this to other cancers where we see the same patterns. And so that was our initial target population. Next slide. And what we did was focus on 6 main attitudinal barriers. So these were known cultural attitudinal factors that came up in the literature over and over and over. So when studies have been done and different groups and researchers talked to people, a lot of the concerns centered around these 6 things. The first was, and I will note that a lot of these things haven't changed, just even in the conversation that we're having today and then the conversation that Chioma will continue on, is basic fear and distrust of the medical establishment across the board, and sort of this white coat issue, rooted firmly in historical abuses that people are aware of and those that people aren't aware of, just sort of storytelling has also contributed to this. The second was a concern about the ethical conduct of researchers. So this idea that I don't want to be a guinea pig, and Dr. Richardson mentioned it, I really am not going to do it, because to a lot of people, they equate clinical trial with guinea pig and testing, when that's in fact not the case. The third was the fear of loss of the type of quality of health that they would receive, that if they signed a research consent form, they either would not get as good care or high quality care, because now they're just a research subject or research participant. And then related to that, worry that they would be treated, that they would treat poor or minority patients unfairly, so that study teams would not have equal treatment for patients from minoritized groups. And then one really key one, and again, still the same, a fear of loss of privacy, that somehow signing that consent form, you're signing away your rights, and you've also given the study team the rights to find out everything about you, was a big deterrent. And then finally, which really came out as a key one, was just a general lack of knowledge and awareness of clinical trials. So what a clinical trial was, what it actually meant, what did it mean in terms of the active treatment that patients were receiving, et cetera. So there was just this general lack of knowledge that this is actually a treatment option in a lot of cases for our patients. The key features when we were developing the intervention was we really wanted, and it was important to have community representation. And so central to the development was a community advisory group who were a key part of us developing the actual content for the video. And these were representatives from different DC nonprofit organizations. We had some government people, we had some actual just community residents, and then folks from faith-based organizations and various consumer and patient advocates. So we were making sure we were hitting all the perspectives, and they approved the scripts, they approved, sort of everything about the video development. And then we worked with a professional video storyteller, because it was really important to have something that was quality and not something that looks like I made it. And so, we wrote that in the budget as an important part. And then we worked with a national recognized narrator. And this was a key piece, because for these types of communication campaigns, and I think Chioma will also speak to this, the importance of having sort of this local celebrity who is oftentimes more trusted than a physician or a doctor or some other person. And so this ended up being key because it really grabbed everyone's attention when they started. And this was actually ABC's Andrea Roan who worked with us on this. And then the really critical central piece was the core content was from real patients, their real stories, unscripted. And, we had we asked them general questions, but everything was filmed just as the words are from their mouth. And that really came across. And this idea of narrative-based storytelling was really the hook for our intervention. And so briefly to tell you who was included in the key in the first initial pilot of it on the next slide. So we were primarily targeting just breast cancer patients who self-identified as Black or African American. It was important for us that they identified rather than we put them in this group or category. They were recently diagnosed with anything other than stage 4 cancer, and that they were anticipating having treatment at one of the participating MedStar hospitals, and over 18, of course. And that one piece was important, that they be eligible for a trial, because there are, of course, ethical issues around having this sort of discussion if the patients weren't even eligible for a trial in the first place. And so what we did was create an actual validated instrument. Another piece of this work that we recognized is a lot of the validated instruments that exist don't actually apply for this population because they're not validated in that population and they're not representative. So on the next slide, I just have a really brief snapshot that I'm not going to go over, but you can take a look at with the types of questions that we asked on our instrument. And we had the patients take the survey before we presented and then had them take it again at various intervals after. But it was, you'll see the questions line up with each of those 6 barriers that we identified. And then on the next slide, just a quick summary of the findings. So for a second part of the trial where it was expanded out beyond our initial pilot, after showing the patients the video, doing a before and after survey, of the 200 patients who participated in this, almost 20% of the patients actually signed a consent to participate in a therapeutic clinical trial. And almost 14% actually went on to enroll, resulting in an increase over and above the baseline clinical trial participation at these institutions of almost 8%, which is highly, highly significant. And so, sort of thinking about it in terms of what it takes to actually persuade or change. I don't like to use the word persuade because obviously, we want it to be the patient's own choice, but really change the way they think about clinical trials. We had a really significant impact. And then 72% of patients actually signed a consent enrolled within 6 months of the larger intervention, which we thought was really important and obviously significant. And then the last piece I want to highlight from this trial, and there's a lot of the details that I didn't go into, but on the next slide, it was really important to see how long after the initial communication, the effects, if you will, lasted. And so you'll see that pre-video, there was, if you looked at the proportion who expressed likelihood to enroll at the trial, about 52% expressed likelihood. And remember, this doesn't actually mean they went on to enroll. It was just sort of their intention to. But then this bumped up to 65% immediately after they watched the video, and that was statistically significant. But even more telling was in the follow-up, which was for some patients up to a month later, and we still maintained that effect, and that was statistically significant as well. And so overall, the conclusions and our learnings from this, what they suggest on the next slide. So essentially, we showed and demonstrated both in the initial pilot and the larger study, the effectiveness of communicating via a culturally tailored video and to successfully improve clinical trial participation among this group of cancer patients. And the overwhelming takeaway is that the intervention doesn't have to be that complex, and something as straightforward as a video intervention can actually be really impactful, and most importantly, rapidly and widely disseminated. And we actually still to this day get lots of requests from different pharma companies, from different study teams to use the video. And so to close it out on the last slide, just reiterating the importance given everything that we've seen and the relative ease of changing the narrative, of having different conversations around these, around clinical trials. the importance of increasing racial and ethnic diversity in our clinical trials. And it remains a challenge, but we've given an example of how it can be addressed. And really the issue being that the advancement of cancer care and the care of other conditions as well, where we see disparities, is really delayed if we don't come up with effective interventions. And the really key part that our trial and others have showed, and I think the current conversation around vaccines is showing, is that it's really critical that we recognize what cultural barriers are being faced by our different racial, ethnic, and other minoritized groups, and really creating our communication so that we are addressing those effectively. And with that, I would like to introduce, I'm really thrilled to introduce to you Chioma Woko, soon to be Dr. Woko, who is at the Annenberg School for Communication at the University of Pennsylvania. And she's conducting health communication and social network research. Chioma is interested in the use of social media as an avenue for public health interventions and for health and wellness campaigns. She's also interested in the use of new media for targeted health behavior change efforts in West Africa. And so how Chioma and I were connected is she was awarded the prestigious Health Policy Research Scholars through the fellowship through the Robert Wood Johnson Foundation, and was matched with me as a career mentee. And she's just doing such fascinating work and extremely relevant on how persuasive messaging efforts can mitigate the disproportionate effects of COVID, of the COVID-19 pandemic, and some current work around addressing vaccine hesitancy. So I would like to hand this over to her to share with you some of her exciting work.
Thank you so much for that introduction, Dahlia. I'm very excited to be here with you all, and I'm excited that GUTS has given me the opportunity to share some of the work that I've been doing. Today, I want to touch on the issue of COVID-19 vaccine hesitancy among Black Americans, as Dahlia mentioned, the inequity issues underpinning it, some of the research I have done in collaboration with my colleagues at the Annenberg School for Communication at UPenn, and finally, some of my thoughts on future research efforts in this area. So as we all know, the COVID-19 pandemic continues to have a global impact on communities and populations. However, the consequences of this current public health crisis have not been equally distributed. In the United States, marginalized populations have borne the brunt of the pandemic, among which are Black Americans. Compared to whites, Black people in the United States are 1.1 times more likely to test positive for COVID-19, we're almost 3 times more likely to be hospitalized as a result of COVID-19 related complications, and are about twice as likely to die upon coronavirus infection. These disproportionate outcomes are not happening by chance or anything pertaining to individual level decision-making. Rather, our population is experiencing this unequal burden because of the social determinants of health. And the social determinants of health refer to the non-medical factors that influence health outcomes. These are conditions which are born, where we grow, work, live, play. These all affect our health and well-being, as do the policies and institutions that make decisions on these conditions. Because these conditions are dependent on institutions and systems, Black people are more likely to live in environments where said conditions are not up to par and are intentionally neglected due to institutionalized racism. Black people in the United States are more likely to reside in overcrowded living conditions, less likely to be able to work from home, and are more likely to have a working environment where social distancing is difficult. And the lack of access to healthcare, healthy food, and clean environments lead to compounded chronic illness that make us high risk for COVID-19. With all that being said, what this means is that these disproportionate yet preventable impacts of the pandemic must be met with intentional and purposive strategies to mitigate the harm and burden that our population is experiencing. At this current moment, immunization is the most promising pathway to an end of this current crisis. However, despite the documented success of vaccination as a public health innovation and important tool for prevention, vaccines are not always accepted by everyone in the population. Vaccine hesitancy has been defined as the delay in acceptance or refusal of vaccine services. It is highly context-specific and complex as a phenomenon, such that what we learn from vaccine hesitancy in one disease area may not be transferable to others. And thus, the World Health Organization has identified vaccine hesitancy as among the top threats to global health because of the implications of vaccine refusal of even a small proportion of people for the well-being of the greater population. In the context of the COVID-19 vaccines, Black adults are least likely to report wanting to receive a vaccine when they're able to, despite cost. Of course, financial and structural factors play a role in whether or not one would want to, but controlling for these issues, vaccine hesitancy remains higher among Black Americans. And the study I will soon delve into will explain a bit more of that. These charts are just some illustrations of vaccine hesitancy across different demographics. A number of organizations have been collecting data on vaccine hesitancy since March 2020. And although vaccine hesitancy has gone down over time throughout the population, Black adults remain among those with the highest level of hesitancy still. This data in particular is from the Kaiser Family Foundation Vaccine Monitor. On the right is data from December 2020, and on the left is from January 2021. On the right, we see that Black people, compared to all others, are least likely to report that they would, quote, get the vaccine as soon as they can, unquote, and more likely to, quote, only get the vaccine if it is required for different activities. On the left, we see again that when comparing racial demographics, Black adults are reporting wanting to wait and see at higher proportions. Now, waiting to see or learn about novel medical technology or healthy skepticism in of itself is not unwarranted, but the drivers of the hesitancy, the particular beliefs fueling it, are what's important. For example, is misinformation exposure driving the hesitancy as opposed to gaps in knowledge surrounding the vaccine? The places we get our health information from play an important role in the health decisions we then go on to make. In the context of COVID-19 vaccines, as in other health areas, trusted messengers are important, as Dahlia mentioned. Whether one trusts a health information source will influence whether they take up the advice of that messenger. For example, research shows that health professionals tend to be the most trusted source of health information across demographics, which is a really good thing because typically our health providers are well-informed experts who are meant to have our best interests in mind. However, in our social networks, both online and in person, there are also people who we trust health information from. But when these individuals are not experts, it's possible that they might be conveying misinformation, whether intentionally or not. Additionally, media platforms from which we might be receiving health information also play an important role in shaping our health beliefs and decision-making. Given factors such as partisanship in the United States, the way the pandemic and the vaccine is being discussed in the media will vary. Also, given the lack of gatekeeping and editorial policies, social media is more likely to contain misinformation than traditional media. In sum, these information sources can shape your health-related beliefs and subsequently behavior. In a survey study I led in my research lab seeking to understand COVID-19 vaccination intentions among Black Americans, we explored the relationships between related beliefs and COVID-19 information sources. At the time we collected this data from May to July 2020, the COVID-19 vaccine discourse was being heavily shaped by partisan influences, given the president at the time and how he was handling the pandemic. Media platforms were also not impervious to these influences, and misinformation on the pandemic in general was pervasive in both traditional and social media. Thus, we were interested in seeing what role prominent messengers and different media platforms might be playing in the vaccine hesitancy observed among Black Americans. So we probed a battery of 6 COVID-19 vaccine-related beliefs among our participants. Note that at the time of the study, the topic of COVID-19 vaccine hesitancy had just risen to the 4 public health priorities, so the beliefs we probed in our questionnaires were adapted from both vaccine hesitancy literature and early reports of concerns that came up in the media. We wanted to see first if comparing Black participants to whites to all others, whether these beliefs varied by demographic, and they did. Then second, and most importantly, we wanted to see if holding these beliefs actually had a relationship with vaccination intentions. Then our third research question was to see if trust in COVID-19 information sources, specifically trust in public health officials, the former President Trump, social media, and traditional media, is differentially affecting beliefs of Black respondents versus those of others. So what we found was that the vaccine-related beliefs were significantly related to people's intentions to vaccinate. as in the attitudes they held towards vaccination is what was predicting whether they would want to get vaccinated, not just the fact that they were Black or any other race. And further, overall, Black people were less likely to hold favorable beliefs toward COVID-19 vaccines, suggesting more vaccine hesitancy, which is then reflected in their lower vaccination intentions. These figures are a representation of the relationship between 4 of the 6 beliefs we looked at with intentions to vaccinate. The slopes of the lines are the same, suggesting that the relationship between the intentions and the beliefs are similar, but what's different is the mean beliefs themselves. For example, Black people are more likely to strongly agree that they would suffer bad side effects from the vaccine compared to others, and also more likely to strongly agree that they can trust vaccine information from public health officials. As for our last research question on the differential effects of COVID-19 information sources on beliefs, we didn't observe any significant findings, leaving more room to further explore that pathway of the role of certain trusted messengers. So despite the interesting results we observed in the previous survey study, there's still a lot that remains unanswered, specifically when it comes to developing a health communication strategy meant to address COVID-19 vaccine hesitancy. The coronavirus is a novel health issue, and given the highly contextually specific nature of vaccine hesitancy, data needs to be collected directly from the population of interest on their specific concerns. And this is a goal of formative research. Formative research will allow you to get an understanding of the set of issues that are serving as either barriers or facilitators to adoption of particular health behavior in the population of interest, which can then inform a public health communication effort. Formative research will also allow you to then take this information and develop tools for public health surveillance, specifically survey tools to track and follow these particular beliefs to see how they are changing over time, how they're impacting behavior, and how they're differentiated across those who are adopting the behavior versus not. In this current crisis, there is a need for urgent response to an issue like vaccine hesitancy, but it should not ultimately supersede the importance of collecting data directly from the populations we care to impact. Involvement of the targeted populations is crucial for the effectiveness of the intervention strategies we aim to deploy, which mirrors what Dr. Wesley was discussing in her segment. Therefore, conjecture among experts will not suffice because we are experts in our fields, but not in the lived experiences of others, despite being members of those communities ourselves in certain cases. There are a number of ways one can carry out formative research. These include interviews, focus groups, elicitation surveys, social media analyses, literature searches, and more. But given limitations of each approach, a few of these methods are typically deployed in tandem in order to triangulate on the most prevalent set of issues. As I'm in the early phases of my dissertation research, I put out an elicitation survey as one of the first steps of this triangulation method. I surveyed Black adults across different age groups, asking about their concerns surrounding getting a COVID-19 vaccine, and these are some of the verbatim responses that we received. Concerns of side effects and other health consequences are common. They mentioned individuals who would be influential in their decisions whether or not to get vaccinated, and they also mentioned some important barriers such as inaccessibility and long wait times. This type of information, which is directly from the population of interest, is what is important to know when trying to address vaccine hesitancy and other issues related to vaccine accessibility in this particular context. It will give the public health community an idea of what issues to address and either communication strategies aimed at encouraging vaccination, as well as systemic issues that are serving as barriers. Finally, although vaccine hesitancy and lower intentions to vaccinate among Black adults continue to be present, what we're seeing with the current rollout is that access is an important issue. There's not enough supply to meet the demand of those who want to vaccinate. There are gaps in information and the sign-up process and eligibility. There have also been reports on more affluent people coming into low-income communities to take up vaccination slots, and data showing that even within healthcare workers who had been prioritized in the rollout, Black healthcare workers are being vaccinated at lower rates. Essentially, while hesitancy will likely remain an issue, there are other issues that have arisen in this current moment that communication priorities might also need to reorient to address where possible. So these are some of the areas that future work would serve to delve into. However, Regardless of the directions this dynamic moment takes us, we must be centering the needs and voices of the populations we serve if we want to continue changing the narrative.